It is a pleasure for me to deliver my lecture at this ISRO course. The topic of my talk will be the use of point-of-care ultrasound as an auxiliary tool during instrumental vaginal delivery. We know that the practice of the assisted vaginal birth is quite common, and more or less it is reported to occur among 5 to 10% of birth. Different instruments can be used. The most commonly used is the ventuse, but especially in some geographical contexts is still widely used the forceps, the Simpson or the Killen for the rotational maneuver. We are aware of the fact that some types of operative vaginal delivery incur into a higher risk of complication, which may regard the mother or the baby, and especially when we feel that operative vaginal delivery may be at higher risk of complication, the use of ultrasound, of intrapartum ultrasound as point of care during the assisted vaginal birth can make things safer. In this paper, the authors have assessed which were the main risk factors associated with a suboptimally placed instrument in the setting of instrumental vaginal delivery. This is a secondary analysis of a randomized controlled trial, the IDUS trial, which was conducted in Ireland a few years ago, 2014. The authors have compared those cases where after assisted vaginal birth, it had been found that the instrument had been suboptimally placed compared with those where the instrument had been more accurately and optimally placed. Interestingly, as expected, those cases where the instrument, forceps or vacuum, had not been optimally placed on the fetal head showed a higher risk of complication in terms of neonatal trauma or need of cesarean section due to failed instrumental vaginal delivery. Interestingly, the authors have compared which were the main risk factors which contributed to a suboptimally placed instrument on the fetal head, and therefore, as seen in the previous slide, to the increased risk of complication of the instrumental vaginal delivery. And among the factors that were found to be more strongly associated with a suboptimally placed instrument, one was the station of the fetal head at mid-cavity, so between 0 and plus 1 centimeter below the ischial spines. Well, so we know that the lower is the fetal head in the birth canal, the easier will be the maneuver of the instrumental vaginal delivery, while for cases where the fetal head is at mid-cavity, these cases have a higher risk of failure, of complication. But based on that, we should be able to assess very precisely the fetal head level in the birth canal in order to understand when the procedure is expected to be more difficult. There is no plenty of data on how accurate is clinical assessment of the fetal head station in the birth canal, but we are aware of some studies which have shown that if we compare the agreement between different operators, different examiners, in the assessment of the level of fetal head in birth canal through vaginal examination, this agreement is poor. In the best scenario is in the range of 50%, but there are cases where the agreement between different operators is in one case out of 5, 20%. On the other hand, there is a tool which is represented by transperineal ultrasound, which allows to have a very reproducible estimate of the fetal head in the birth canal. through the measurement of some parameters that can give a real estimation of which is the true fetal head level in the birth canal. The two parameters that in the last 20 years have been first introduced and then validated as those more useful and reproducible in assessing the fetal head level in the birth canal at transperineal ultrasound are the angle of progression, which is assessed with the probe placed sagittally on the perineum of the mother, or the head perineum distance, which is the linear distance between the skull and the skin of the perineum, which is assessed with the probe placed axially on the perineum. Both parameters have been shown to be extremely reproducible, much more reproducible than the clinical assessment of the fetal head station. Moreover, several studies, observational studies, have shown that thanks to the use of these transperineal sonographic parameters, we may more accurately than digital examination predict the outcome of a vacuum procedure. This is a study coming from France, which has enrolled 235 women submitted to a vacuum extraction just before the procedure. These women were assessed at transperineal ultrasound with the measurement of the angle of progression. The authors have compared the 205 cases where a successful procedure with the 30 cases of failed vacuum extraction, showing that between these two groups there was no significant difference in terms of clinical station. Then the clinician was not able to understand which cases were more likely to fail, while this assessment at transperineal ultrasound of the width of the angle of progression was able to discriminate the case at higher risk of failure, because in this group, the cases that failed, the width of the angle of progression was significantly narrower compared with the width of the cases that had a successful extraction. Similar results were obtained in this multicentric European study that was led by a Norwegian group. In this study, 222 women submitted to vacuum extraction were enrolled, and just before the procedure, it was assessed the station through transperineal ultrasound by measuring the head perineum distance, which is the other parameter that I mentioned before. And interestingly, it was shown that the larger was this distance, the head perineum distance, the higher was the risk of instrumental vaginal emergency cesarean delivery due to failed procedure. And interestingly, the length of the head perineum distance was able to predict the duration of vacuum extraction, which was significantly reduced for cases of head perineum distance below 2.5 centimeters. Very recently, a collaborative study from France and the University of Parma, which was my former setting, has enrolled a large number of women submitted to mid-cavity vacuum-assisted delivery, and in this group of women it was measured again the head perineum distance at transperineal ultrasound axial approach, and the studies have shown, as you see, more than 951 cases of women, 950 women were enrolled. Interestingly, again, among the predictor of a failed mid-cavity vacuum extraction, it was found that there was this sonographic estimate of the fetal head station, the head perineum distance, while the clinical station did not enter the model, thus confirming that the clinical assessment of the station is not as accurate as a sonographic assessment of the station in predicting a difficult or a failed procedure. Going back to the paper which has analyzed the risk factor for failed instrumental vaginal delivery and suboptimal placement of the instrument of the fetal head, it was shown that beside a mid-cavity station, the other strong risk factor for a suboptimally placed vacuum or forceps, and then for a procedure which has a higher risk of failure, there was the fetal malposition, so occiput posterior or occiput transverse. Well, why we believe that in cases of malposition there is a higher risk of a failed instrumental vaginal delivery? There are actually two main reasons. One reason, especially for cases of vacuum procedure, which is the most commonly type of assisted vaginal birth. In case of occiput posterior position, the deflection point, which is exactly the point of the fetal head where we should apply the cap of the vacuum, is more distant, is deeper in the vagina, so more difficult to be reached by the operator. So this can make more cumbersome the ability, can make more difficult the ability to place the instrument on the right place and then to proceed with the fetal extraction. The other reason is that for occiput posterior position, the mechanism of the fetal head descent is different compared with the occiput anterior position, because the fetal head must descend posteriorly in the birth canal, occupying the concavity of the sacrum, and just at the level of the lower part of the birth canal, through a movement of flexion, can be delivered. So the direction of the axis of traction is different compared to the occiput anterior position. Well, we have recently submitted, the paper is under revision to the American Journal, the first series of cases of vacuum extraction in sonographically confirmed occiput posterior fetuses. Actually, in this almost 100 cases, the rate of failed vacuum was extremely low, was 4%, which is comparable to the general rate of failure in case of operative vaginal delivery. And we found that among the predictors for a failed vacuum extraction, the head perineum distance was significantly different between the failed procedure versus the successful one, while the angle of progression did not turn out to be different. So while especially in vacuum or occiput posterior position, the HPD works well and works better than the angle of progression. Well, we expect that usually these two parameters should change progressively and in parallel. The lower is the fetal head in the birth canal, the shorter should become the head perineum distance, and the wider should become the angle of progression. This has been shown by several studies, and usually based on the width of the angle of progression and on the length of the head perineum distance, this corresponds to the clinical station. So for instance, when the fetal head is +2, the angle of progression should be around 140 degrees and the head perineum distance 2.5 centimeters. But we should be aware of the fact that in case of occiput posterior position, the direction of descent of the fetal head is different compared with the case of occiput anterior, because as I said, and as you can see in the lower part of the slide, the OP fetus goes downward, occupying the concavity of the sacrum, and just at the level of the lower part of the birth canal, by using the symphysis as a fulcrum, undergoes a movement of flexion to be delivered. So it may happen that while in occiput anterior position the head perineum distance becomes shortened in parallel with the widening of the angle of progression, for the OP fetuses it may happen that we have an apparently favorable angle of progression, while the head perineum distance remains still large. This is a case where we have an angle of progression of 140, which should correspond to a fetal head station of +2, while in fact the true distance of the fetal head from the perineum remains larger, remains more than 3.5 centimeters, which testifies a fetal head that is not well engaged. So due to the different mechanic of descent of the occiput posterior fetuses, we should really trust more on the head perineum distance rather than the angle of progression when we are dealing with the vacuum extraction of a sonographically confirmed occiput posterior fetuses. Thanks for your attention, and I'll be waiting for your question during the Q&A time.